Thank you so much. Thanks for the introduction. It's an honor to be here. Grew up in Papillion and I moved away over 20 years ago. And so it's always great to be back in Nebraska. There really is no place like Nebraska. And to see these organizations, the ASAP and ICAP, is just amazing the work you're doing. I hope you know that it's not like this everywhere else and should really serve as a model for other states. Hopefully can keep it going. I have nothing to disclose except that I am a new empty nester and my ideas of hot topics might be relative to that. I've suddenly become interested in bird watching and might take up pickleball, but receive no money or conflicts of interest. So I'm really excited to share these topics with you. The first one is precision medicine and leveraging the electronic healthcare record for improving empiric antibiotic selections in pneumonia and UTI, and then also a little bit about intra-abdominal infections and skin and soft tissue infections. And the next topic is kind of elevating your stewardship program to a next level with sort of a novel strategy of opt-out stewardship and in a tele-stewardship format. And then the beta-lactam allergy management. I mean, after Dr. Thorpe's, we might just need to cut this out altogether and just start over square one with the patients. But I can share a few things on the horizon and a novel approach to that. And then there's another topic that I will share later. I don't want to ruin your day just yet. And just in case, this talk goes badly, at least we have the real hot topics here of Husker football in the 90s and Runzas. So I feel like you could just talk about these for the next 45 minutes and be good. But we have to earn some CE. So the first topic is precision medicine to improve empiric therapy selection. We know this is a problem, right? We don't know what the patient has. We don't know their risks very well. We take a shotgun approach. Dr. Morgan showed you that bullseye with all the bullet holes kind of around the bullseye. And that's kind of what we're faced with just due to lack of information at the point of decision-making when ordering antibiotics. So these two trials they're called the INSPIRE trials, and there's kind of cohorts, sections that they have included in this. So one trial, but with two arms, and one was pneumonia and one was urinary tract infection. And the acronym INSPIRE comes from Intelligent Stewardship Prompts to Improve Real-Time Empiric Antibiotic Selection for Patients. So that is a wonderful acronym, and I think it goes up there with all the cardiology trials. Deserves awards for that. So the goal of this trial, these two trials, is to compare two different strategies to determine best practices for empiric antibiotic selection. One arm is routine care, so regular antibiotic stewardship strategies, and the second arm is a smart prompt alert intervention. So the smart prompt alert will provide the physician or prescriber at the time of order entry an alert that's tailored to specific to each patient, the type of infection and type of multi-drug resistant organism that their antibiotics are being prescribed for. And if their risk for a multi-drug resistant organism or MDRO is less than 10%, the alert will recommend a standard spectrum antibiotic choice. So in this population, this is 59 hospitals in a large healthcare system across the United States. And the patients were non-critically ill adults that were hospitalized with either pneumonia or UTI. And you can see this is done in a large number of patients in each arm. Pneumonia was about 100,000 patients, and UTI was about 120,000 patients. And so the 59 hospitals were randomized to either the smart prompt that alerts them of the patient-specific risk or routine care. And the primary outcome was extended spectrum antibiotic days of therapy, so within the first 3 days of admission. And then their balancing measures were time to antibiotic escalation, ICU transfer, and length of stay. So here's what the workflow looked like. You have a patient either in the non-ICU unit or in the ED or in the ICU. If they're in the ICU, the algorithm and alert is suppressed over here on the gray side. If they're in the ED, they'd ask the question, is the patient ICU bound? And if yes, then it goes to the suppression of the algorithm. And if no, then it goes over to the regular algorithm that they would present to a patient in a non-ICU unit. And if they order an extended spectrum antibiotic for either pneumonia or UTI within 3 days of admission, they require an indication on the antibiotic order, then the algorithm and prompt algorithm was initiated. If their patient-specific risk for a multi-drug resistant organism was less than 10%, so over on the left, then they would get an alert saying that to recommend ceftriaxone as a standard spectrum antibiotic. And if it was greater than 10%, it would just allow them to continue through the completion of the order. And continuing on this, here's a screenshot of what the alert looked like and the content of that. It says if they're ordering cefepime is not recommended for empiric therapy because this patient's risk of Pseudomonas pneumonia, it's very specific to the organism and infection for that patient, is less than 10%, ceftriaxone is recommended. And then this risk, it kind of provides them some more information to kind of help them feel comfortable about it. This risk is calculated based on known patient and hospital factors at admission. This recommendation does not account for positive cultures this admission or allergies. So not perfect, right? And it also does not replace clinical judgment like no alert should. And then their options are to either cancel when they would return to the order screen or override the alert in the red box there. And then they'd have to enter a reason of why they're overriding the alert. So due to allergy, patient requires ICU care for infection, a positive MDRO culture this admission or from an outside hospital that maybe the alert didn't pick up, neutropenia or other, and they could free text it. And if they put selected replace, it would take them to the ceftriaxone order screen. So the results, so the pneumonia and UTI frameworks were set up exactly the same, just different trials. The primary outcome for pneumonia, the SMART prompts had a 28.4% reduction in empiric extended spectrum days of therapy, and UTI had a 17% reduction. And there were no differences in the length of stay, days to ICU transfer, or days to antibiotic escalation. In the pneumonia trial, the risk of an MDRO was very low. It was 4%, and over 96% of patients in both risk groups. They measured the risk in both groups, but only showed the alert in the one arm. Is 96% in both risk groups were classified as low risk. I mean, both arms were classified as low risk. And there were less than 2% of patients that were classified as low risk for pneumonia due to an MDRO that eventually did grow an MDRO from the blood or respiratory source. So, the risk assessment isn't perfect, and, accounted for, 10% was set as the threshold as kind of a expert consensus, acceptable risk. So in the risk models, you can see like each risk model was an MRSA pneumonia, Pseudomonas pneumonia. And in the red squares, I have the number of patients that were classified as low risk, but did grow an MDRO. So, 1%, 0.5, 0.7, 1.3, very low percentages. And we saw similar results in the UTI section. Greater than 94% were classified as low risk and less than 6% classified as low risk. eventually did grow an MDRO from the blood or urinary source. So these graphs are very interesting. On the bottom we have timeline starting in the pre-implementation, which was back in 2017, and runs up through June of 2020. And on the y-axis we have days of therapy per 1,000 patient days. The orange lines are the standard spectrum antibiotic groups, and the dark blue lines were the ones that had the the that were ordering extended spectrum antibiotics and received the alert. So the closed orange line, the very top line, is the patients who had the smart prompt shown but were ordered standard spectrum antibiotics, and the open orange circles were routine stewardship and ordered the number of standard spectrum antibiotics. So you can see the separation start there. The little gray area in the middle was the phase-in period, and you can see almost an immediate separation between those two, between the prompt and the routine stewardship. And the dark blue lines below are the extended spectrum days of therapy. The open triangle, so the third line down, is extended spectrum antibiotics in the routine stewardship arm, and the closed triangles are the extended spectrum antibiotics in the CPO bundle. So fascinating timeline. And if you can see this, it goes up through 2020. It kind of marks when the IDSA pneumonia guidelines came out, and when pandemic started kind of over to the right. And you can see that that the antibiotic use was still decreasing, and when a lot of antibiotic use at other hospitals was going up during that awful time. And we saw similar results in the UTI section. So almost immediate, separation within 3 months of implementing it in that phase-in period, and kind of sustained separation there. It gets better. They sent out quarterly reports to the hospital executives and to the individual physicians. So this peer comparison is very effective. I know it is in my system. People are very competitive with one another. So they would send out the number of protocols that were, or number of times that antibiotics were ordered per protocol and compared to the other hospitals, and then per clinician. And they blinded the other names of the clinicians, but you could see yourself of where your numbers were. And then they broke it down into how many times you're ordered per protocol, how many times was declined or overridden. And then they also tracked like what the reasons were for those overrides. So just a little background on how they did this. What is making the prompt smart? The antibiotics ordered are over on the left, and then over on the right side of this table is the pathogen that's included in the risk estimate. So color-coded this. So if they ordered vancomycin for either pneumonia or UTI, it would calculate their risk for MRSA pneumonia. And in the green, cefepime, if they ordered that, and Pseudomonas, was in both pneumonia, UTI, it would calculate it would return the risk for Pseudomonas for either pneumonia or UTI, whichever one they're ordering it for. And same with meropenem, it would return the risk of an ESBL or resistant gram-negative rod or Pseudomonas. Now, how did they determine these risk factors? They looked at over 500,000 hospitalized patients over 3 years within their system, their hospital antibiogram for pneumonia and UTI patients only, and looked for risk factors just for these MDROs. And they included demographics, comorbidities, history of an MDRO, history of prior hospitalization, ED, nursing home visit, prior antibiotics, and labs. And they used a very sophisticated, it's a little bit over my head, it's machine learning called CART. It's basically a machine learning method to predict risk. And I just had a diagram there that kind of shows a schematic of it. It kind of parses the variables in order and determines which ones are most important in predicting these risks. So what were the risk factors that they found? They had, separate models. So MRSA, pneumonia, patient history of MRSA, and facility percent of MRSA of all pneumonia being greater than 2.5%. That's not new to us, right? That's in the guidelines. And Pseudomonas, patient history of Pseudomonas, and same thing, antibiogram, Pseudomonas with pneumonia with Pseudomonas greater than 2%. And the ESBLs and the carbapenem-resistant Enterobacterales, none of the risk factors predicted a risk of greater than 10%, which I found very interesting. So basically, anyone ordering meropenem for pneumonia would have the risk factors over 10%. Now it was between 5 and 10%. So like we said, like the 10% is, arbitrary. You could set that at whatever you wanted. And similar to UTI, history of the organisms, antibiogram, percentages of resistance, and some other things were included, like male sex, patients on Medicaid, and some labs. But again, CRE, no risk factors predicted greater than 10%. So those are the pneumonia and UTI trials that came out first. They were published in 2024. They just released the skin and soft tissue infection and intra-abdominal infections sections that I won't go into, but the framework is the same. Primary outcome in skin and soft tissue reduced, the SMART prompts reduced extended spectrum antibiotics by 27% and in intra-abdominal infections by 35%. And again, no differences in length of stay or days to ICU transfer. These were just published in April. I know they were presented at ID Week. So my takeaways for this is I feel like this is definitely the direction we want to be moving, right? We want more information at the time of decision making to help clinicians pick the right antibiotics. The problem is we don't know. So there's this fear of the unknown. What if they have Pseudomonas or MRSA and things like that? But so that's the direction we want to head. I was impressed by how quickly the results were shown within 3 months, and I think that attests to this wasn't an education thing, and Dr. Lavorsi's talk really resonated with me on this of having information at the point of decision making that's sustainable, and also carried them through a pandemic and times of disruption. And we can see things like this that's programmed, like baked into the stewardship workflow, can help sustain your antimicrobial stewardship efforts. The risk factors are not really transferable between facilities, right? Because they looked at their own patient populations. So that, I think, is sort of a theme for the day on a lot of the things I've heard. Is it feasible? Is it transferable? It's really hard, right? They had a very complex way to determine their risk factors, and not everyone has a bioinformaticist like Joshua. And we need to clone them everywhere, right? And it would also require sophisticated IT programming to program the alerts and key in the factors that would show the correct alert to the right patients. So very challenging. I hope this is the direction we're going, and that we have, a commercial product like Dr. Harrison was mentioning. We need commercial platforms to make this routine care and, integrate into the electronic health records. All right, my next category is next level stewardship with an opt-out model. And this, I love this paper and this approach. Is a large community health system in Kentucky, 4 adult hospitals, over 1,600 beds. And the problem they're experiencing is their prospective audit and feedback method was not very efficient and not very effective. Demands a lot of resources, kind of inconsistent, delays in communication, and lack of provider participation. So they decided to implement an electronic antimicrobial stewardship program, which is essentially telestewardship, and an opt-out antimicrobial stewardship approach. Like we heard earlier from Drs. Morgan and Laborsi, like make the right thing easier to do. So their patient list, they would run a patient list every day, and I probably can't see this, but you can get the concept of what their list looks like, and then their columns. The list had all patients with active orders for systemic antimicrobials, and the columns kind of showed alerts, like if they were on broad spectrum antibiotics or duplicate coverage or on a restricted antibiotic or a bug drug mismatch. So kind of lowish hanging fruit in need for stewardship interventions. And then when they click on a patient at the very bottom, so face up, very efficient, down at the bottom, they had a nice little summary stewardship report that summarized their antimicrobial orders, cultures, labs, vital signs, imaging, and respiratory charting. And then they had a little place there where they could document whatever their note is. And then when they did document that, it would add a check mark in the ASP reviewed column. So it was a really efficient way to keep track of who's been looked at, especially, transferring between pharmacists and things like that. Then they could create a custom recommendation with sort of the standard template of current antibiotics, current day of therapy, what the antibiotic recommendation was, like discontinue, de-escalate, set a stop date, or if they wanted to recommend starting something else, and could enter the drug dose and duration, and then the clinical reasoning, like completed course of antibiotics due to culture and susceptibilities and things like that. So this would populate the alert. And after they complete this form to populate the alert, they would go in and actually enter the orders. But they wouldn't sign them yet. They just enter the orders and have them and save them as saved work in the orders activity of the electronic health record. And so they're just kind of pended there waiting for the prescriber to either sign them or remove them. So the alert then, when the physician opens the chart, displays all the things that they just filled out on that form. This is a recommendation from the ASP to reduce incidence of MDRO and C. diff infection. Current antibiotics, Piptazo day 3, indication, cystitis, antibiotic recommendation, de-escalate to cephalexin to complete 7 days. Clinical reasoning, narrowing spectrum. Please select defer if you are not managing these antibiotics. These recommendations are ready to be signed or edited in manage orders. And their options to address the alert are agree, defer to another provider, decline some or all recommendations, or review the chart and then manage the orders. And so if the pended orders if the alert is not acted on, this will be, it tells them recommendations will be implemented in 24 hours if no provider declines. It's not automatic though. I'll get to that in a minute, but that's what the alert says. And now this, just keep in mind, this is only used for, kind of low-hanging, pretty straightforward recommendations to discontinue. You've got cultures back, straightforward kind of things, discontinuing, de-escalation, or setting a duration. Patient's getting better, set a duration. If there was any need to escalate an antibiotic or that required a nuanced discussion, some exchange of information, then those would require direct contact with the physician. So then back to that patient list that the pharmacist works off of. If the alert was rejected, it would display an X. And if there's no declining of after 24 hours, the pharmacist then would review their chart again. They're not just going to go implement, and go implement those orders that they had pended in the saved orders. They'd still make sure everything looked, made sense, patient's still improving, there's no new information that would change the recommendation. And if that were the case, then they would enact the orders and go ahead and sign them. So they started off with this as a pilot. So I always love implementing pilots before launching anything kind of massive like this, kind of kick the tires on it, work out kinks, learn some lessons. And so in the pilot, they developed the empiric recommendation. So this isn't just, Joe pharmacist on Tuesdays recommending this. These are guidelines that are approved by the stakeholders, the med exec committee, medical directors, and P&T, and some education was provided to providers and pharmacists, and then they implemented the pilot over 3 months, and they showed a pretty good success over just these 3 months that justified hiring 3 more full-time pharmacists so that a pharmacist could be available on site at each hospital. There were over 1,000 recommendations made with a 69% acceptance rate, and a pretty small number implemented. So 14% were implemented after not being rejected for 24 hours. And over 5 years, they have shown a decrease in days of therapy by 25%. So I really like this strategy. I think it has a lot of positives. It's could be beneficial in settings where, community hospitals, especially where there's not, provider-led rounds, where it's harder to find the physician, track them down. You don't want to time their rounding. You don't want to have to wait for their return page, things like that. There was some anecdotal positive feedback from the medical staff that they liked an actionable alert, and that some appreciated the minimally intrusive nature. I think some limitations, just like any alert, we just keep adding more alerts, could contribute to alert fatigue. And I also think that maybe the timing of the alert, the trigger action of opening the chart might not be the optimal time, since the provider hasn't seen the patient, hasn't reviewed the labs themselves. So, that could be something that I think could be optimized. And like I said, this might not be feasible at other institutions. Like I said, they had a pretty advanced, patient list and recommendations, and then also creating the alert. And on the other side, some providers are going to want face-to-face conversations. So you're going to have both ways there. But overall, I think this is a good strategy at maybe a lot of places and maybe not some others. I also think the tele-stewardship model will help increase reach to maybe hospitals that don't have as many resources. And it also, I think it could be extrapolated to other clinical pharmacy, not just stewardship, right? So other clinical pharmacy specialties. I like that it's kind of aggressive with the opt-out approach and makes, like we said, the opting out will make it just sort of easier to do the right thing. And but it also could be difficult to replicate. All right, next level beta-lactam allergy management. I think we just probably need to start over with we would do the pen fast. I'm going to talk about Ceph fast, but I don't know. Maybe it's not even worth it if the patients aren't going to want you to delabel them. So we're all pretty familiar with those fascinating information. We're familiar with, the percentage of patients who report an allergy to penicillin, and up to 95% of patients think they're allergic and are not. We're aware of all the badness that having a penicillin allergy label results in: increased mortality, increased adverse events, prolonged hospital stays, readmissions, costs, surgical site infections, C. diff, MRSA, and VRE. Just badness all around, right? So we want to delabel them, and we have right now these three options. Taking a history can sometimes just take care of these, like their allergy on their chart is just a headache or nausea. And then for other lower risk patients, we use the PenFast clinical decision tool to assess their risk. And for low risk patients, we can do the direct oral challenge. Has been validated more and more in a lot of studies. And then the skin testing, which maybe that's what we do. We usually reserve for higher risk, or maybe if they just want it, they just prefer it. Like we found out with Dr. Thorpe's presentation and research. So just a refresher on the PenFast scoring tool, you're basically asking time, is it been within 5 years or less since the reaction? Did they have anaphylaxis or angioedema, a severe cutaneous adverse reaction, or was there treatment required for the reaction? And then it scores them if they're less than 3, so 0, 1, or 2, considered low risk. And studies have demonstrated that they can safely receive direct oral penicillin challenge, and recommended or even can be given without allergist expertise. And the American Academy of Allergy, Asthma, and Immunology position statement strongly recommends that penicillin allergy evaluation should be performed proactively in patients with a penicillin allergy label. So trying to make this routine practice, it should be done at routine visits before they actually need the antibiotics. So including in children and pregnancy. So we're, getting there. It's a lot more awareness and implemented a lot more everywhere, but still not really a routine part of practice in a lot of places. So I really like this study, and this is sort of exclusive information. I knew my friends at Houston Methodist were looking at this and implementing this, and I emailed them to find out if they had published anything, and they just received that day acceptance for publication. So this is PenFast, implementing PenFast in the electronic health record with a nursing assessment. And the goal of this study is to compare the nurse assessments with the stewardship pharmacists to see how they did. They had 4 hospitals in Houston. They included 338 patients. Now, they implemented a modified PenFast questions, I think, to sort of differentiate some of the risk scoring to make sure that none of the patients get miscategorized as low risk. And then when they evaluated the scores, they hid the nurse scores, and then the pharmacists went in and scored them themselves, and then they compared the two. These are what they did to modify the score. Like they increased the score for anaphylaxis or angioedema to 3 points. So that would automatically kick them out of a direct oral challenge if you're going by the PenFast. And they assigned 1 point for any unknown responses, and assigned 4 points for any of the delayed hypersensitivity reactions like Stevens-Johnson's and such. So the nurse would screen the patient upon admission and enter it into the electronic health record. And then the scoring tool in the electronic health record would calculate the score and have it as a discrete field in the section of the allergies. And I mentioned that they would the pharmacist would go in and interview them again and have their own scoring, and then they assess them blinded. The pharmacist also asked if they ever tolerated amoxicillin or amoxicillin clavulanate, just I think as an extra, like, why not? I'm here. Let's see if they've already kind of had a direct oral challenge. And the results are interesting. But here's where it looked like in their charting, part of in their admission workflow. And it's when they're screening for immunizations or medications and things like that. And the questions are, were standardized with some standardized answers, which is nice. And the results are they were an 84% agreement with what the stewardship pharmacists obtained. There were, and then this is the interesting part, there were a pretty high percentage, 34% of the patients reported tolerating amoxicillin or amoxicillin clavulanate after their initial reaction. And in 69 of those patients, so 59% of those patients that had received amoxicillin or amoxiclav had reported anaphylaxis. So like I said, sometimes history just takes care of these things on their own. Now, this I think is interesting. There were 72 patients, so 7.8% that were high risk, but falsely classified as low risk. Like we don't want that. Like that could be, you don't want to, give them a direct oral challenge when they really should be in the high risk category. And then 7.6% of the patients were low risk and falsely classified as high risk. So I think in this study, I think it's a great idea, especially in places that might have limited stewardship resources. Nurses are in a great position to do that, right? When they're doing their admission assessments, standardizing the questions is beneficial to provide more consistency between assessments compared to open-ended reporting. And it might be an easy way to kind of easily identify patients who could be candidates for delabeling or antibiotic challenges. And I also like how the information is readily visible at to the prescriber when they're selecting antibiotics. And this could also be scalable. I do think, like I said, like this may not work everywhere. Like how much more can we ask nurses to do? There's, nurses are amazing members of the stewardship team, but also know that they could keep getting asked more and more to do things and are stretched pretty thin already. And I'd also like to point out, like we saw in those errors that were miscategorized, even though the number was pretty small, that it doesn't eliminate the need for a clinician reassessment before doing an antibiotic challenge. So you wouldn't just like look at a score and just, go, not make sure that that's accurate and that, they truly would be low risk before you would give an antibiotic challenge. So I think it could be an effective approach. I think there's pretty good concordance with the pharmacists that did the assessments, and feasibility may vary among hospitals. I think the ongoing education could be difficult, especially, we're still not there like with this being routine care yet. So, and I think you'd have to kind of have ongoing education for staff turnover, new nurses, and things like that. But I also like the direction this is headed. I think maybe it's not nurses, but I like having it in the chart so that it's right there and you can easily identify patients and have it right there visible for the prescriber. Just a brief mention on CEPFAS that I think is on the horizon. I was only in abstract form right now, but it's from the same group in Australia that did validated the PENFAS score. And it's basically a tool that is under the same framework as PENFAS to help determine low risk patients who have a cephalosporin allergy listed. And their results were a 5.7% had positive results of allergy testing that had a low risk score of less than 3, negative predictive value of 93%, and sensitivity 93%, and specificity 72%. So just kind of an FYI that this could be exciting and another tool that we have in our toolbox for assessing risk for direct oral challenges, and if utilizing cross-reactive cephalosporins. Okay, another thing. This was the thing I didn't want to ruin your day with, and I'm sorry if, maybe take a deep breath. Okay. Is it time to reevaluate remdesivir use? I don't know if you're like our health system, we haven't really reevaluated our remdesivir criteria for use since we first implemented way back. However, we are in a different era now, right? A lot of people are vaccinated, have had COVID, and there really is limited data to support routine use in the modern era where there's a higher rate of seropositivity. The trials we have, the data we have are from 2020, 2021, where most people were not vaccinated or had not had an infection yet. And our guidelines even haven't really been updated since early 2022. The NIH guidelines just disappeared. And so the IDSA guidelines uh, still say have conditional recommendations with very low moderate certainty of evidence. And basically the criteria are used for anyone in the hospital within 7 days of symptom onset and an oxygen requirement. So this group, very bold and brave, I think they just decided to test it out in their 8 hospital health system in a pre and post quasi-experimental design. They restricted remdesivir to adult patients that were symptomatic, requiring oxygen, and immunocompromised, or if they had an ID consult. So immunocompromised here is really the limiting, the much narrower criteria for use. And they did this restriction in the time frames where the pre-intervention data is from June of 22 to May of 23. And the post-intervention is July of 23 to 24. So just last year. So more recent times. And this is in adult immunocompetent patients, about a little under 5,000 of them. They had 3,000 pre-intervention and about 1,500 post. Their primary outcome was adjusted outcomes using medium risk covariate values, and they found no difference in 14-day all-cause mortality. And in their secondary outcomes, they also found no difference in 28-day all-cause mortality, 30-day readmission, or length of stay between the two groups. For ICU admission and ventilator days, remdesivir was associated with lower risk in the pre-intervention group, which we know that, right? And it was actually higher in the post-intervention group, which was likely because it was being used in only immunocompromised patients, so sicker cohort there. Symptoms were not assessed, and it could have been potentially underpowered to detect differences in mortality. And so in the pre-intervention, just of note, they had 37% of patients received remdesivir, and in post-intervention, 4.1% of patients received remdesivir. So they decreased the number of patients by 33% and saved 1.5 million in drug costs. So you may not know this if you're not a pharmacist, but remdesivir is number 6 on the top drug expenditures of all drugs in non-federal hospitals in 2024. So that's higher than alteplase. It's higher than all the mAbs that I don't even know what they are, the immunotherapies. That's pretty high up there, and it's just very expensive. And I know your C-suite would love to see any reductions in that. But my takeaways for this are it's reasonable to maybe reevaluate the criteria that we have. I'm not sure what exactly those are. It probably is beneficial in some people, right? But we also maybe don't want to be giving it to patients that won't benefit from it. So reevaluating it in this modern era of widespread seropositivity, I think is reasonable. It's may not feel comfortable though, like veering from guideline recommendations. And so the problem with that is we just don't really have any new data to update the guidelines. So that's a problem. But I will also point out that, fiscal stewardship isn't something we always focus on, right? It's most important, like patient outcomes. Sometimes that's the most expensive antimicrobial. but it is important if we're using it in patients who maybe not be benefiting it, because you can really use those resources to support other efforts. But I do think we'll likely see more institutions following suit on this. And I know some of my colleagues from Nebraska Med in here are on a group kind of discussing this with the Midwest Antimicrobial Stewardship Collaborative. So those are the hot topics in antimicrobial stewardship. There are a lot more. I really would love your thoughts on any of that and open to questions. This is I'll leave you with my favorite sign when I come back home. And also a picture of my kids back in 2010 when the last year of the College World Series was at Rosenblatt. And you can see most of us were having fun. She's a pistol. She's spicy. But yeah, so in Creighton, Nebraska, both winning their conference tournaments and going to regionals. So go baseball. Thank you. Sorry.
Helen, if anybody else has any questions, come up. I wanted to get it started with a question about penicillin allergy assessments and if any of your hospitals have implemented tools or systematically try to do any of the labeling efforts.
Yeah, so we haven't been real systematic about it yet. We have it in a guideline, but it's just kind of there for people to use or not use. So, haven't really implemented it in any workflows. We have a very enthusiastic allergist from with WashU that is kind of championing this effort now, and we're actually looking at building a patient questionnaire that would be we have Epic, so it would be in my chart. And so going to try to pilot that at her allergy clinic.
Great, thanks.
Yeah.
And Dr. Ashcroft is here. He has an important announcement.
Thank you. I think a couple of announcements. So one will be that we will have a break right now. And but before we go on to break, I just wanted to inform everyone that, there is a water safety workshop, a water system safety workshop that is taking place a week from now in Lincoln. That also our team has collaborated with NICN and APIC Nebraska to put together. So if you can attend that one too, please go ahead and register. The registration is still open, but I think it will not remain open for very long because next Friday that they have to do it. But if you cannot attend, just have someone else in your facilities. Just let